You have a movie of your original surgical technique done with mallet and gouge and no operating microscope. It would be of definite historical interest to see this old movie.
The operation on the endolymphatic sac, which we have used for several years with good results, is based on the fact that many vertigos are caused by hypertension of the endolymphatic fluid in the labyrinth. Here we see an endolymphatic sac localized in the thickness of the dura mater, which surrounds the lateral sinus. This lateral sinus is our landmark. We trephine for it, progressively removing bone until we reach the region of the endolymphatic sac, which we find attached to the posterior wall of the petrosal bone, where the canal enters the aqueduct of the vestibule. It is at this site that the sac is opened. Here we see the technique of the operation. After hemostasis has been effected, the landmark of Henle's spine is sought, and the trephine is applied to a square area of 1 centimeter behind the external auditory canal and below the horizontal line across Henle's spine. This trephination is effected with mallet and gouge, or with the aid of an electrical forceps, working in the above-mentioned square. We are sure of working in a sound part of the mastoid bone. An anterior X-ray has given us information regarding the exact position of the lateral sinus. Where it goes into the mastoid, as far as the lamina interna, which appears to be glossy and in places even bluish. This is the exact part which should be above the lateral sinus. Thus approaching the lamina interna, we find it as shown, perfectly exposed, with a blue tinge that indicates the place of the lateral sinus. It is here that the bone of the lamina interna must be opened to expose the lateral sinus, which is our second landmark, as we know that the region of the endolymphatic sac must be found facing it. Here is the exposed sinus. The opening is now enlarged so as to expose chiefly the anterior part of the sinus, taking great care not to open it, which would make it impossible to continue the operation. The lateral sinus is now exposed. We find it blue with a sharply defined anterior boundary and the beginning of the white dura mater, the presinusal dura mater, the presinusal triangle, which is now perfectly visible and which must be simply augmented in order to establish the point at which the dura mater adheres to the bone. Here we find our third landmark. With great caution, very small fragments of the lamina interna are now broken so as to enlarge the presinusal triangle, which has been in full view all the time. Thus we attain an unobstructed view of a larger part of the dura mater. All this must be done with painstaking care in view of the proximity of the lateral sinus. Here is the region where the dura mater is exposed under the lancet, exactly in front of the lateral sinus, which is seen to disappear in the posterior aspect. Here we probe with the lancet to establish whether the dura mater is adherent, the fact which tells us that we are in the right place. The white dura mater is now perfectly visible, and here, in front of the lateral sinus, we make an incision with a curved bistoury. A few droplets of endolymphatic fluid flow out. These may be visible or invisible, dependent on the quantity escaping. This gauze tampon prevents a small hemorrhage, and will be removed after 48 hours.